call the roll.
Senator Saslaw, Senator Barker,
Here.
Senator Dunavant,
Here.
Senator Suderline,
Yes.
Senator Lewis.
Here.
Mr. Chair, we have a quorum.
Great. Have we got a sign-up sheet? Well, I've got bad news for you. Well, actually, Senator Stewart's first up anyway.
Here's behavioral health. This is Alexis, and this was
Thank you, Mr. Chairman. Members of the committee.
Yes, sir.
and then that's the
I've
bill.
got Senate Bill
So most of that's not
361.
bad.
Mr. Chairman, very quickly, because I know you all have a lot to do. The Marcus Alert System was an incredibly good idea, an incredibly good initiative, and I was very supportive of it until it became a mandate, an unfunded mandate on these small jurisdictions. And the problem we have in rural Virginia is we simply don't have the capacity to do this yet. And so as I looked at this and I talked with many of these folks, and many of us received, I know many of you all received the same letter that I got from the Middle Peninsula Northern Neck Community Services Board, where they just simply can't even find the staff to do it. But under the Marcus Alert, they've got to come up with a plan this year and then implement it by 2025. And it seems to me that if we let Prince William work and others that are doing it, show them how it's done, we can then develop a model, and these smaller areas can probably do it more effectively, more efficiently, and more economically, and do a much better job. And so what I have proposed here is to make this a local option. The folks that have already started have already started. There was some money allocated to help their teams get going. So let's let the bigger jurisdictions, and I've had another thought, we may want to do this by population, I don't know. Let's let the bigger jurisdictions get going on this and develop the system, and then we can help the small areas roll it out and not try to force it on them, because they can't do it right now. It's just too much for them. That's my bill, Mr. Chairman.
All right. Thank you, Senator Stewart. Any questions from the subcommittee for Senator Stewart? Anybody here speak in favor? I'm sorry.
Mr. Chair,
Yep.
Chair, yeah.
Senator Barker.
Senator Stewart, under the dealing with the situation that some of the rural areas have, and obviously we do have several of those, and several of the community services boards are really relatively small in terms of the number of people they're serving. Would it be feasible to have some of those areas be able to contract with a CSB that might be the one for, say, Fredericksburg rather than the one for down on Planning District 17 and 18 to help provide services in that area?
It may be in the future. The problem is you're going to find that areas in Fredericksburg are having difficulty. They're doing it.
Right.
Stafford's doing it, Fredericksburg's doing it, Prince William's doing it, but they're going to have their own difficulties right now. You can't find the staffing for this, is what I'm told, by the local CSBs. So I think my idea is this: if we let the bigger jurisdictions do this, develop the model, then we can help the small jurisdictions do this in a few years. Rather, it doesn't make any sense to make them have a plan now that doesn't have to be implemented until 2025 anyway. I understand why it was done that way, but this gives them some flexibility, and I think we can help them better later on, is my strategy.
Yeah, and Mr. Chair,
Senator Barker.
and I assume that then there might be a range of options as to what would work and what would be most efficient and how it would work in terms of the specifics of each of those individual situations there.
I think so, because we can then learn from those that have implemented it, and we learn the mistakes and we learn the successes, and we can do a much better job. And the smaller areas will be more inclined and more able to do this. That's my thought process.
Okay. Mr. Chair,
Senator Barker.
I don't know whether you mentioned this earlier, I may have missed it. Is there a definition of what would constitute one of these smaller areas? Is it number of population size, or what?
I've got a motion.
Okay.
Chairman's got a motion.
I would move that we set a population threshold of 80,000 or more.
So
Or,
anything
yeah,
under.
under
anything
80,000, right.
It would be a local
Optional,
option for
yeah.
now. Mr. Chairman,
That's an amendment, folks.
Mr. Chairman, that doesn't cover all of my jurisdictions. I have been in this General Assembly long enough to know that I better take what I can get. And I consider that a friendly amendment.
Been moved
I'll second it.
seconded that we put a population threshold of 80,000 in Senator Stewart's fine bill. All those in favor say aye.
Aye.
Aye. Opposed? All right. So there we have an amended bill before us. So you've heard the amendment. Who else wants to speak in favor of 361 as amended?
Mr. Chairman and members of the committee, I'm John Jones, representing the Sheriff's Association, and we certainly appreciate the accommodation. Senator Stewart has explained this bill very well. We support it.
Thank you. Next.
Good afternoon, Mr. Chair, members of the subcommittee. I'm Katie Boyle.
Please use the microphone.
Oh, do you want me to use the microphone? Sorry.
Can you get it? There. There you go.
Absolutely. I'm Katie Boyle with the Virginia Association of Counties, and I think Senator Stewart did a great job laying out the concerns here. We really want this initiative to be a success, and we are happy to work with the state on making sure that localities can comply and that, behavioral health crises get a behavioral health response, and we're committed to working with the state on funding and staffing and rolling this out, so I appreciate your consideration. Thank you.
Thank you. Anybody else to speak in favor of 361? Yes, ma'am. Come forward.
Hi, this is Jennifer Faison with the Virginia Association of Community Services Boards, and we actually were here to see how this was going to play itself out in service of moving the ball forward, but allowing for some of the contingency planning to occur, especially given the comment that Senator Stewart made about the timing of the plan versus the implementation and all the things that can happen in between. I would say the amendment that you just adopted, and I don't know because I haven't had a chance to think this all the way through, but my guess is that if you have a CSB catchment area, for example, like the Middle Peninsula, Northern Neck, where you have I believe it's 13 localities within the catchment area of that CSB. And you had individual localities who were either above or below that 80,000 threshold in that catchment area. How would you skip over or skip, it within a CSB catchment area where there were jurisdictions with more than 80 who could participate, and then some with less who wouldn't want to? So I don't know if that is something that needs to be contemplated further, but certainly support the idea of that flexibility for localities too.
Would you like to do a study on that and see if there's a better number, and I can offer it on
Mr.
the
Chairman?
floor?
Yep. Senator Donovan.
Would localities work better, or would you still have the same problem where some localities wouldn't be participating and some would?
It says localities, I think.
It says localities,
Yeah.
but if she
But if
would
you-
like to look, I can see where there may be a few of those, but
Yeah, I
the
can't
bigger
imagine.
jurisdictions are going to do this, and they have their own CSBs unto themselves. The Middle Peninsula, Northern Neck, I don't think there's any county over that. And the other CSBs that maybe somehow Senator Suderline's area, I don't know. Maybe we just need to look at those numbers and
Yeah, if you want to take a look at
Or
it.
is it a better way to define it than numbers or maybe there's a different way to define this? I don't know.
Well, I think we're
So
trying to
they
get at the
don't
smaller
have
jurisdictions.
mosaicism
Yeah.
in there.
jurisdictions that
Yeah.
really can't do this right yet.
Right.
But I'm happy to, with the chairman's and the committee's approval, if we need to adjust that number, we can do that through an amendment. If you want to look at those numbers, and we can.
Can you do that
figure
for
out
us?
if it's a better
We
one.
can certainly do that. I think we would more broadly support the ability for that collaboration to occur at the local level, regardless. So you could find yourself in a situation where you would have maybe all of the localities in a catchment area that agreed they wanted to move forward with it, And we wouldn't want to do anything that would be preventative of that or that would discourage localities from joining together. So in keeping with the spirit of what you're trying to do here, I think if we had an opportunity to look at the numbers, we could certainly do that. I don't know that you're going to find a number that's going to fix it for every catchment area, but we can figure that out.
All right.
Mr.
thanks.
Chair.
Sorry, Senator Barker.
Yeah, I think it should not take us too long to figure this out. There are 40 CSBs around the Commonwealth. Dickinson County is by far the smallest population, where there's just a single small jurisdiction. The area around Rockbridge County, there's I think the second smallest, and what would be helpful would be for a couple of us to look at the population totals and the utilization of services in some of the others that are relatively small population. And it seems to me that we probably should do this based upon the Community Service Board size there rather than just a jurisdictional size, because then you end up with sort of a mishmash of things within one CSB. And I think we could easily reach agreement in terms of what would be a size that would be appropriate in terms of population to have the volume to be able to support it. And in your area, 17 and 18 are all in one CSB. So there's those two are in that one CSB there. And so
Except
I think
I don't know how you make it a local option if you change it to a CSB coverage area
right.
versus locality. And remember, a local option is not a prohibition
right.
against them. And I love your comments and I appreciate them, but this is the sort of thing where we're not going to get everything we want. So we're trying to get a little bit to help
Right.
at least as many as we can. So what did somebody smart tell me one time? You don't want the perfect to be the enemy of the good.
That's correct.
Understood. And I guess I'm wondering if the initial language doesn't include anything about population. What was the driving force behind including that?
To try and help the smaller jurisdictions out who aren't are going to be up to speed to implement this, yeah.
So you would be defining it so that when it was time to implement, you would be knowing which ones you needed to help?
No, they can
Okay.
they can opt out, yeah.
Right, but they could opt out whether you said below 80 or above 80,
No.
not with the amendment.
Before Senator Stewart's
For the
bill.
bill, everybody's compelled to do it.
Understood.
It's clear to me that this committee is not willing to say everybody in the
Full
state
local
can opt
option.
out.
Understood. Okay.
So there was an amendment offered that
Gotcha.
says jurisdictions under 80,000 people,
Right.
which I think is a
Reasonable.
very reasonable compromise.
Okay, all
Very good.
right. Anybody else to speak on 361 as amended? For or against? Anybody? All right, the bill as amended is in front of us.
Move to recommend report, yeah.
There's a motion to recommend reporting and a second. And so we're moved and seconded that Senate Bill 361 as amended be recommended for reporting to the full committee. Clerk, call the roll.
Senator Barker,
Aye.
Senator Dunavant,
Aye.
Senator Suderline,
Yes.
Senator Lewis.
Aye.
Ayes 4, no 0.
All right. Thank you, Senator Stewart. Thank you for your good work. Senator McDougal, you're up.
Thank you, Mr. Chairman. 580.
Yes, sir.
Mr. Chairman, I had a constituent reach out to us a number of things.
Sorry, Ryan.
Thank you, Mr. Chairman. Mr. Chairman, I had a constituent reach out to us about the triennial audit requirement for hospice and home care organizations. They had a number of other issues about the new regulations that went into place. I believe it was last year that required the triennial audit, and there were some other matters, but this is the one we brought forward. I'm not sure that they're here, but they felt it was a challenge for them to comply with being audited every 3 years, particularly for the smaller entities that do this home
Okay.
healthcare, this home care and hospice.
All right.
So this would repeal that triennial audit requirement.
So there'd be no audit requirement.
Mr. Chairman, that's what we put forward, but certainly the committee, if it was, they felt in our conversations with them that every 3 years for these small organizations were relatively expensive as well and onerous. So they asked us to move forward with repeal, but I'm sure that any sort of relief they would be appreciative of.
All right. Senator Barker, do you have something?
Chair, Senator McDougall, do you know whether the agencies that are the smallest ones are the home care organizations or the hospices?
Mr. Chairman, I believe the constituent that contacted us were a home care organization, not a hospice, but but it was all under the same, and so when it was drafted, it had the both.
Senator Barker.
Quick comment on that. I think that this would likely to be more of a burden for the home care organizations than the hospices, because the hospices have more types of personnel involved, and
Right.
many of the home care organizations have only one or two services they're providing. So,
Mr. Chairman, if that's Senator Barker's motion to amend to remove hospices and only make it home care organizations, I'm amenable to that.
I would.
This is not my area of expertise either, so I was hoping to have constituent backup.
That's right.
You also have the same bill.
Oh, do you?
Yeah.
You got the same bill?
Oh, okay, excellent.
Thank you.
Did you make an amendment?
I would make a motion that we
620.
limit this to the home care organizations,
580.
so that
So on line 12, it would strike 4 hospices and.
Right.
Just hospices.
yeah.
Okay. All right, that amendment's in front of us. Anybody want to move it? Sure. Anybody want to second it?
Second.
All right, it's been moved and seconded that it be amended, that Senator McDougall's bill be amended to remove hospices. All in favor?
Aye.
Aye. Opposed? Okay. Now the amended bill's in front of us.
Chairman, I don't want to stop your progress, but Senator Evans' bill, they style it differently, but that it would require the department to amend the regulatory code to exempt non-skilled home care organizations. I think this one is more direct in how it gets there, but I think it's ultimately the same goal.
Yeah.
Okay.
So what would you all like to do?
Yeah, do y'all want to,
Roll mine into Senator McDougall.
is that what you want to do?
Whichever is,
Yeah.
that would be fine with me, if that could be a co-patron.
I will move that the
Bipartisan
subcommittee
cutting regulations.
recommend incorporating Senator Evans' Senate Bill 626 into Senator McDougall's Senate Bill 580, and that Senator Evans may be made chief co-patron of Senate Bill 580.
As amended.
Want?
580 as amended, right?
Yep.
Okay. Is there a second?
Second.
Moved and seconded that we roll Senator Evans, what is it, 626?
626, yeah.
Yes, sir.
626 into Senator McDougall's 580 as amended. All in favor? Aye. Opposed? All right, so we've got one unified effort across the aisle here on this. Is there anybody to speak to the amended rolled-in bills? Sir, come on up.
Good afternoon. My name is Mitch Opalski. I'm CEO and owner of Synergy Home Care in Northern Virginia, and I was here to speak to Senator Evans' bill. So I'm glad they're combined. Yeah, just definitely in favor because the smaller agencies, this is going to be a cost burden every 3 years. And the other part of it was we weren't sure what the objective of the audit was. If it's for fraud prevention, it should be confined to Medicaid agencies, and a lot of smaller non-medical or non-skilled home care agencies aren't in the Medicaid program. So this is a win for everybody, I think, because it seemed like an overreach on small businesses as far as regulation. So thank you.
Okay, yes, sir. Anybody else? Nobody else speak either in favor or against of 580 or Senator Evans 626?
Move to report.
All right, it's been moved and
Recommend reporting.
moved and seconded that we recommend reporting Senate Bill 580 as amended, which includes Senator Evans 626. Clerk will call the roll.
Senator Saslaw,
But this is to do what?
Pass 580 as amended.
Merge the bill into.
No, pass it. We're passing it. We've rolled it in already.
This is to report.
Report it. Recommend report it.
Aye.
Barker,
Aye.
Senator Dunavant,
Aye.
Senator Suderline,
Yes.
Senator Lewis.
Aye.
Ayes 5, no 0.
There you go, sir.
Thank you, Mr. Chairman. Would you like me to be at full committee, or?
I don't think you need
No.
to. If you run into trouble, we'll let you know.
Thank you. Thank you. all
Senator
very much.
Sorrell, 350.
I really have to thank Senator Evans for making me go to the House now.
What you got?
Thank you, Mr. Chairman. I thought this was a pretty simple bill. Well, a couple of people have pulled my sleeve with a couple of questions they have. But so before we had electronic medical records. This has to do with electronic medical records and audit trails. So before we had electronic medical records, if something changed in your record, you'd usually see a scratch and something new written there. But ever since we have electronic medical records, when somebody makes a change in the record, you can't tell it's changed. So you can't.
Not true.
Well, and every once in a while, some of the systems I've seen, there'll be a teeny tiny, little tiny footnote.
An example, a real life example, for instance.
If somebody decides they want to go back and change the progress note they put in the chart, they can go back and change the record, and when you get the record printed up, it's a clean copy. And so the software will generate what's called an audit trail, where you can go back and see the changes that were made. And I just wanted to make clear that the audit trail is part of the medical record, and that you can request it without a subpoena, or without discovery, or without having to have a big fight in front of a judge. It's just part of your medical record is a complete record, so you can see that everything was done to your record when you request it. And that's basically all this says, is that the audit trail is part of the record itself. That's what it does. There's a little bit of concern about the cost of producing that audit trail and how you would fit that into cost request, which they just raised with me, which I didn't get their note, but I think that's what the question is.
Mr. Chairman?
Senator Donovan.
I just have to disagree with the premise here. So I have an EMR. I have a few that I use. You have to lock your notes. You have to lock your notes, and once you lock your notes, you cannot change any of the substance of the record. You can only add an addendum. And so, each note, there are parts of the record, like problem list or things like that, change or dynamic, but because they're live, but the notes are all locked, and we have to lock them to bill. You can't bill without locking. And so for my EMR to have to institute an audit trail for something that, I don't have control over. I just know that we have checks and balances that are already built in for documentation, so that you can't go back and change it, because that's a premise of medical documentation. And so I'm not sure this is something that we need to, A, legislate, B, we might be generating an entire cost to an EMR without it actually producing anything.
Mr. Chair, I would say is that, at least in terms of the commentary I've gotten so far, nobody has disputed the premise that there is such a thing as an audit trail which shows any changes that were made. And I think I don't know what system you use, I'm not sure that all these
I think
systems.
every system's, you have to lock your notes.
Okay. Well, all I know is that there are audit trails, and they exist, and I wanted to make sure you can get it without having to file a lawsuit.
Have you encountered this in practice or anything? Have you encountered it in your practice?
So we're saying your first time you didn't have seen.
Changes made to the record, not in the last 12 months or the last 2 years. Maybe they standardized their practices more.
Because it was electronic, you couldn't tell a change had been made to the record.
There was, after it was explained to me how to figure it out, it was very tiny little notations and stuff that you could key it off of, but you had to really know what you were looking for to know to go look for something else.
Right, gotcha.
And, Mr. Chairman,
Senator Dunn.
I would further assert that everything I put in my medical record is dated in time. Even if I put it in retroactively, when you had paper, you could go back and write anything you wanted to on a paper note, but you can't do that on electronic medical records. And there are people here that run electronic medical records. We have hospital systems that have Epic. We have MSV. We have all sorts of people here that can address this, but I don't know the cost or the liability to somebody who's documenting, but I can tell you, I cannot fathom the risk, but we can talk by better subject matter experts than just me.
Let's see who's here. Well, let me start out first. Is there anybody speaking in favor of Senate Bill 350?
Good afternoon.
Yes.
Chair Mark Hicks on behalf of the Virginia Travelers Association, and we support the bill. What's nice about this bill is it will allow us to get access to this important information in the absence of litigation. Thank you.
Anybody else in favor of 350? Anybody want to speak against 350?
Afternoon, Mr. Chairman, members of the committee. Scott Johnson for the Medical Society and the Virginia Healthcare Association. Anybody touched one of these today, an audit trail will tell you what keys you pushed, when you entered it, all of that. Commonly in litigation and medical malpractice, plaintiffs' attorneys ask for audit trails. So you think of all the text and emails you sent today, sometimes the request is for a day's worth, an hour's worth, or an entire case. And the attorneys work out what the cost is to produce it. It can run the gamut from pushing an icon and uploading all that information on a thumb drive, all the way to many people having to pull down this information from computers, from the electronic health systems like Senator Donovan was talking about. And those systems don't operate for free. So whether you're a one-person physician practice, a two-person dental practice, a nursing home, or a hospital, somebody's got to be there to answer the request. And it has worked well. Every malpractice attorney that I've talked to said the judges have said you're going to produce it, you're going to pay for it, and it's operation, and I know of no problems that I've encountered as I've been calling around asking people about it. But if you put this language in the statute, it means every patient, anytime they request the records, they can ask for it and incur that cost. Another practical problem in the bill, if you look on line 35, it talks about you have to produce any changes in the records. So suppose I have two patient records, and I'm supposed to enter a progress note in this one, and I screw up and put it over here. If you're telling me I've got to now produce that note, I'm violating the federal privacy laws under HIPAA because this is somebody else's chart. So I know Senator Somerville is very well intended, but the practical implications make this bill a bad idea, and we'd ask you not to go forward with it. And I will be glad to answer any questions or hang off to some of the others you'll hear from in the healthcare community.
Have you talked to these folks about this?
Mr. Johnson sent me a letter, which my staff never gave me, and so I'm sorry.
I checked his notebook. He doesn't have it.
Yeah, and the hospital association told me they had concerns, but we haven't talked.
Is there any?
I could fix that last problem you raised with 3 words.
Do you want to go by for the week? Or you want to try and do it today, or what do you want to do?
Let's go by for the week because I hear these guys want to do their bills.
Okay.
That's fine. Are you going to meet next week?
Yeah.
Okay.
Plan on it.
All right.
All right. Bye for the week. Anybody have no objection to that, right? No. Bye for the week. All right, who we got next? We got Boy Scout.
I have the order on.
Did Emmett, you never signed up either.
We'll get it. No, it's not on there. We'll get it. Was he? All right, ready?
Yes, are you?
Shoot.
Can you hear me? Okay, here we go. Mr. Chairman, today I present SB 448. And the draft that you have in front of you seeks to amend the existing law on hospital regulations, including screenings for patients experiencing domestic or sexual violence. I'll give you a couple of other examples of screenings at a doctor's office or at a hospital. VCU, right here in Richmond, had a policy where everyone who came in would be screened for bike safety. They would ask you, do you have a bike? Do you have a helmet for your bike? Another one is in the pediatrician's office asking if a family member has a gun in the home. And if they have a gun in the home, then they would ask them about safety, locking it up, and all that stuff. So there's plenty of examples where this has been successfully done and it has not been too burdensome. You know, it is a tragedy that around 1 in 7 men and 1 in 4 women will experience intimate partner violence at some time in their life. I can tell you, as an individual, as a child, I was a victim. We used to have to escape and go spend the night at the neighbors. And finally, my uncle had to come and take us 2 states over, where we lived for a few months because my father, who had some challenges, hurt my mom. So this is really personal to me. And, you know, during the pandemic, we know that abuse has become more and more prevalent. And many of the people who are experiencing this violence don't know where to turn. They don't know who to talk to. They don't have the capacity to find help for themselves. You get in a box and you stay in that box because that's what's safe. You don't want to bother anybody. You don't want to put anybody out of their comfort zone. You live in fear. So we believe that healthcare professionals are uniquely positioned to help individuals who are experiencing this trauma, domestic and sexual violence, because they already have an established relationship of trust and care. And I know that our Senator Donovan, you know, has the trust of her patients. So this bill would ensure that professionals are using just a unique, you know, screening for signs of abuse, documenting those related injuries in the patient's medical record, and refer the victims to crisis intervention services. You know, I believe that in order to best handle these sorts of situations, healthcare professionals will receive training and on how to identify and care for the victims. It is imperative that we build the network of support for men and women who are facing this type of violence. I know that we have it in our communities in all parts of the state. And having somebody, you know, to fight on your side, to stand up and say you're going to be okay, is just life-saving. So we had this conversation with the VHHA, and there is some heartburn on their part. I'm sure they're going to tell you about it. They would prefer that we do more of a work group to collaboratively explore with stakeholders what the best practices would be. I obviously think that we should have the capacity to handle that, and it already has a, you know, an enactment clause that would be putting it off a little bit longer. But I do hope that you all will take this seriously and consider, really, we are in a very difficult time in our country. I have some speakers who are here to support it, and I will, you know.
Senator Borsco,
save my
mine
time.
does not have an enactment clause.
Well, it's supposed to have. It was supposed to have a delayed enactment from.
Mine does not.
We would be willing to look at that, perhaps, if that was.
What is your
the case.
recollection of what it should have had?
I thought it was going to say 2024, so we would have a year to get ready for it. But of course, maybe we would need we might need an amendment or something for that. That was, I guess, one of the things that we discussed as a possibility.
This is a substitute. It does not have an enactment clause.
Okay.
It's a substitute.
Okay.
If you want it.
Oh, you want to, have you got a substitute?
I have one,
Okay.
but
You want to use it?
I would really like us to consider
The original bill?
the original.
Okay.
Yeah.
Do you want to put the enactment on there, the delayed enactment, or just?
If that would be easy, I mean, if you all would feel more comfortable about delaying it a little bit. You want to hear from the speakers first?
Yeah, let's hear from the speakers first.
Okay. So I have just been told by one of my stakeholders that we do want the substitute because
Substitute,
it has the
okay.
consent language in it.
All right.
Excuse me.
Anybody going to move the substitute for us? I'll move. So moved, and I'll second the substitute. All in favor? Aye. Okay, substitute's in front of us.
So the substitute, and I apologize, I've been in a different committee all
all right.
afternoon, and it has been
What's the substantive
Yeah.
difference?
Yes, please. Thank you.
Mr. Chair, there are two minor differences with the substitute and the original bill. The substitute adds a requirement of consent for the provider to notate in the patient's medical records that they are a victim of sexual assault or domestic violence, and it requires the provider to inquire regarding giving or revoking consent to provide medical records to a third party.
Okay. All right, so we've got the substitute in front of us, so we've heard how it differs from the introduced version, and Senator Boysko says she has some folks here to speak in
Yes, sir.
support of Senate Bill 448.
Yes, sir.
Come on up.
Good afternoon, Mr. Chair and members of the committee. My name is Fatima M. Smith, and my personal experience, along with others who you will hear from today, informs SB 448. While in graduate school and shortly after, I was in an abusive relationship and hesitant to share because I was actually working in the domestic and sexual violence field. I found myself at a local doctor's office here in Richmond, Virginia, and their intake form asked, "Have you ever experienced physical or sexual violence?" With a lot of hesitation, I circled yes, and to my surprise, when I was brought back into the exam room, neither the doctor nor the nurse followed up. It was a great missed opportunity to connect me with resources in a space where I felt should have been safe. I began to think about the other survivors I work with who may not choose to disclose ever again because of their lack of follow-up when they disclose on an intake form. I also thought about the survivors who may be in imminent danger, and it was in that moment that they would need support and referrals. I also think about the survivors I work with while I worked at the Richmond City Juvenile Domestic Relations Court, who struggled to obtain a preliminary or emergency protective order because they were told they don't have sufficient evidence. This bill would actually allow for survivors to consent to to abuse being documented in their medical record, and if they later wanted to seek legal remedy, they could then ask for a copy to show a history of abuse. Research tells us that most people who experience domestic and intimate partner violence will not report to police. Instead, they will go to a friend, a family member, or a trusted individual in the community, such as a doctor. SB 448 provides patients who are experiencing abuse the ability to consent to have this documented. And we know that this bill is not the single remedy for domestic violence, but it is a public health issue, and passing this bill represents that we as a community are committed to addressing this public health issue that has in the Commonwealth increased significantly due to the pandemic, but being survivor-centered. So I urge you to consider passing it as the substitute with enactment.
Okay, come on up.
Can I ask a question? Can someone direct me to where the enactment is?
No, she's already, we plowed that ground. There is no enactment. Yeah.
Okay,
Yeah,
thank you.
it was inadvertently left out, and we may choose to put it back in, and we'll see how things go.
I misunderstood. I thought it was in the substitute.
No.
That's my
Yes, ma'am, state your name, who you're with, and
Hi, good afternoon, Chairman and subcommittee members. My name is Abby Phillips. I'm here today because I'm a survivor of assault, and I'm here to support this bill. The act of a single assault or an ongoing abuse in someone's life is the beginning of an incredibly painful journey that often involves shame, physical pain, anxiety, and depression that survivors often learn to hide from the outside world. And they do that in an effort to protect themselves from more trauma, from more violence. The mental and physical stress can often manifest in physical concerns, and often those physical concerns lead the survivor to the doors of their medical practitioner. Medical practitioners are in a unique position to build a trusting relationship with their patients. I know I personally have a lot of trusting relationships with my medical practitioners. So we're using this bill to hopefully empower medical practitioners to become part of a network to help those who are surviving or experiencing abuse. I also have a statement from another survivor of intimate partner violence who could not be here today, but asked me to read their statement if I can take a few more minutes of your time. On the morning of November 5th, 2017, my intimate partner and I were in my vehicle driving from Danville to Portsmouth, where we resided at the time. My abuser became angry with me, and before we left in the car, he was verbally abusing me. We stopped at a gas station and the verbal abuse continued. It then escalated and my abuser attempted to push me out of the car on the passenger side repeatedly. My abuser eventually used his body weight to pin me down in the car. Our 1.5-year-old son was in the back seat witnessing the abuse. I fought frantically to get from underneath his body weight as he said through clenched teeth, I wasn't any good for anybody. Eventually, my abuser picked my body up and slammed me into the concrete. My head hit the pavement hard and my vision was distorted. He walked away and I blacked out. When I came to, some people were standing above me and told me an ambulance was on the way. I asked where my son was and found out later he was in the car. The ambulance took me to the hospital. I was given fentanyl and discharged with papers about general assault. No one from the hospital followed up to check on me, educate me, or even help me understand what interpersonal violence looks like, or provide any resources on how I could remove myself and our son safely from the situation. Thank you for your time.
Thank you. Is there anyone else to speak in favor of 448? Yes, ma'am.
I'm here to speak on behalf of Lisette Johnson, who is a survivor, and due to her injuries from the abuse, could not be here because she's a high risk for COVID due to her lung condition. My name is Lisette Johnson. In 2009, my verbally abusive husband of 21 years walked into our bedroom with a gun as our children played nearby and shot me. He continued shooting me as I ran past him. My 12-year-old daughter sent her 9-year-old brother out the house to get a neighbor to call 911 while she came to see what was happening. As I was running away from the house, she watched as my husband, her father, took his own life. I was a soccer mom, a dance mom, a business owner. My kids were in school, and my kids were in the school with their kids that they had gone to preschool with, We lived in an upper middle class neighborhood a few blocks from the James River. We didn't fit the part. Not to our pediatrician of 12 years, not to my gynecologist of 12 years, or her predecessor of 15 years. Not to my primary care doctor, who still insists they don't see any domestic violence cases in Midlothian. Not to the gastroenterologist I consulted for undiagnosable stomach pains. Not to the neurologist I consulted the same issues. Not to the doctors at Patient First. Not to the ER doctors at St. Francis. Not to the doctors at Tucker's Inpatient Psychiatric, or even my therapist. I had seen every one of them in the months preceding my husband shooting me. Not one ever asked me screening questions to determine what was really going on behind my undiagnosed health concerns. No one ever asked me if someone was hurting me, insulting me, threatening me. I am what domestic violence looks like, and my story is the story of healthcare providers that don't hear because they don't ask. Abuse doesn't always look like black eyes and broken bones. Every single medical provider in their careers and their offices sees many people just like me. We know screening works in the healthcare setting where it already is implemented. Making those screenings universal would provide an opportunity to affect many other women, children, and individuals, so their outcome may be different than ours. Outcomes without the profound trauma my children and I navigate to this day. Before the irreversible physical injuries I experienced and the ongoing costly related medical interventions I continue to endure in 2022. Because of my compromised lung function from the shooting, I have asked Fatima to testify on my behalf. Thank you for your time.
Thank you. Anyone to speak against Senate Bill 448? Everybody loves it.
Mr. Chairman, members of the committee, Brent Rawlings of Virginia Hospital and Healthcare Association, not here to speak against the bill. We were referenced earlier in the conversation. We did reach out to the senator. We spent some time with her staff this afternoon trying to understand the bill better. We haven't seen the substitute, so I can't really comment on whether or not it's anything that we can accommodate swiftly or whether an enactment would be needed. But ultimately, just wanted to let you all know that we have been working on this, and we did not get. The reaction we got from our members in response was, well, we do this. And certainly there are screenings that are done routinely in hospitals on domestic violence and sexual assault. And we really wanted to understand better where the areas of improvement are needed, where the gaps are, and I think that's one of the reasons why we were interested in a work group, and I think that's something we can still do regardless and will need to do to better understand how we can address the serious issues that we obviously have. And hearing from the previous speakers, we understand the importance of that. So I just wanted to kind of come up and say that. Don't have any opposition. Again, we will continue to work on this. If there are any major issues in terms of tweaks to the language, hopefully the Senate will commit to work with us going forward, and we will continue to work on it. Thank you.
Is there any, you got a question?
I do.
Senator Donovan?
I'll see what you have first. Well, I have a couple of questions just as I look at the documentation. I don't know, like I might, if I need them, I'll call them that. Is this a bill that's replicated from anywhere else that's doing this? In hospitals, this documentation that can be used in the chain of reference, that can be permission given or not given? Because that's a dovetailing of the legal world and the medical world. And, I'm curious if it's been put into practice anywhere.
Thank you. So, Mr. Chair, Senator, excuse me, 19 other states are doing it as well as Puerto Rico. They've enacted laws that healthcare professionals are receiving training on domestic violence.
So that's different. Training I get. That's different than the documentation requirements here, because there's first a documentation requirement and then there's a permission, and I would say I would be horrified and brokenhearted if I missed a patient that came in that was in crisis. I know I do, because it's 1 in 3.
Yeah.
And they don't always confide in you.
Right.
I think that confidence is going to come in a relationship in an office more than in a hospital and an ER where there's already chaos. Chaos is really bad right now. I mean, we are boarding COVID positive patients. We are boarding mental health distressed patients because we can't get them for TDOs and into the hospitals. And this bill is directed towards that setting, which when the one was read about the person who was in a mental health hospital or seen by her I think there are arenas where we need to target this. Gynecology is probably one. Primary care. I don't know if the ER is. And I just, from a medical legal standpoint with the documentation, I would love to see us do a work group on this and actually raise Virginia to a performance standard that would be what it should be to care for women. And it's bad this year. And it's really scary. And I think some of our crises interventions with the Bravo services and the crises, holding areas that we're setting up. I know that we have to fix this. I just don't know that this is the way that we can get the solution. And we're about to put a lot more on our ERs that are, and they may not even be the right place. I don't know. I don't know if I would talk to an ER person. It's helter-skelter in there.
Senator Boyska.
So, Mr. Chair, since 1995, California has had these written policies and procedures. In 2015, Massachusetts passed a law that the boards of registration in medicine, nursing, physicians, assistant nursing home administrators, social workers, psychologists are all receiving training and education on domestic and sexual violence. Alaska has established a state law mandating the Alaska Council on Domestic and Sexual Assault produce standards and procedures for delivery of service by healthcare providers. And you might have more to share.
And I'll also add that we know in Virginia, Black women who experience intimate partner violence are 3 times more likely to be murdered by their partner. And particularly in communities of color, we are seeing and you probably know this, seeing an overuse of ERs instead of primary care because they know they won't be denied service. And so I think it's really a both and you bring up a great point that the standard is our medical offices, whether they're affiliated with a hospital or not, to provide this, but we are seeing an increase of people reporting to emergency rooms for related and unrelated things, such as domestic violence. And the YWCA of Richmond also was in support of the substitution
Okay. So is this a model piece of legislation? I mean, is this identical to what's been introduced in other states?
This was similar to California's, modeled after California's law.
I would just implore that we look at this, to see if we're penetrating into the right areas for train everyone. I totally support the training portion of this. We're going to need a FISC. We're going to need an investment to do that. I think there are probably some pretty inexpensive ways we can do it with national organizations. But I would love to see us do this. I just have concerns about this actual model and the fact that it's focused on the ERs at this moment in time. And I wonder if you would consider a work group this year, which I'm happy to participate in. I'm happy to work with you. I have no intention of harming your intent at all. I just, I would like to get to the problem really well, and I don't know that we've defined it right with just focusing. Hospitals, just because hospitals have this doesn't mean that hospital-employed doctors will get it in their office. They won't. This will just be at the hospitals. And ER consumption is up, I agree. But I feel like the relationship part of medicine is in the 12 years, the 17 years. So I don't know if you would consider doing a work group to look at this and see how we could actually build a system.
I'm wondering if perhaps you might look at just medical providers then instead of having hospitals.
But
and
then
that way
I
you would
I
get
don't
it to the
have-
right people.
I would have to redo my EMR to document the way you want me to do it.
So-
and then I have this, I would have to talk with we're talking about legal counsel to ensure I have consent and chain of custody. This is, you know what it's like when you have a chain of custody.
Yes, ma'am. Mr. Chair and Senator Donovan, so this says shall require each hospital to develop and implement a written policy and procedure. So it doesn't say that it has to be a blanket. It says each hospital or it could be each medical professional or service provider.
So if you would consider, and I will tell you, a lot of the hospitals have them. I don't
Right,
know how
yeah.
good they are. But if we could strike the language about this chain of custody and the documentation and the medical records, and we could talk about all hospitals having a policy and procedure, and then a work group to look at how we actually train, educate providers, and figure out how we can reach women in the places that they are that we're missing. And then we can figure out if documentation goes with that and chain of evidence. Happy to look at all of that, but I think that's the part that's.
Are you proposing a work group or to amend the substitute?
How about would you consider if we work on this week and see if we can get the language and do this next week? Would that be okay?
Yeah, that would be okay. And Mr. Chair, I'd also like to ask for yet a little amendment on Part V on page 256 on section lines the 6. The consent should go with the forensic nurses specifically, correct?
The chain of custody.
The chain of custody,
So
excuse me.
It's written so that we're saying documenting, if I'm disclosing, like if I went to the doctor and said my chest is hurting, they would write that in the file. If I'm saying I was experiencing verbal abuse, they would write that. But the collection of evidence, that and the chain of custody, that actually came from our consultation with forensic nurses in Virginia who said they wanted to make sure that the legislation would be that folks who are trained to do that, which is forensic nurses and SANES, sexual assault nurse examiners, would be the ones to collect that. We're not saying other nurses and other like primary care physicians. They're not.
Not all hospitals have forensic nurses.
All right.
Motion to take it by.
Yes, please, now.
The bill go by for the week.
Thank you.
Second. And we'll work on it, and hopefully come back, we won't hear any more testimony next week, okay?
Appreciate it.
All
Thank
right.
you.
Thank you, Senator. Senator Hanger, you were here before Senator Peterson. Sorry, Senator Peterson.
I was here before Peterson. No, you weren't.
No, you weren't. Were you?
We need to find some more patrons.
What you got?
Thank you, Mr. Chairman, members of the committee. I have Senate Bill 119, which deals, and I'm going to offer just a moment, a substitute, but I want to explain how we got to this substitute. I think we have this worked out. What this is when you have individuals that are experiencing behavioral health crisis, they are evaluated typically when they're under emergency custody order by a community service board. And then the process, if they're going to a hospital, they end up in an emergency room, and the being evaluated for a temporary detention order. It requires the CSB to share basic information they've discovered in their initial work with the individual. The bill, as introduced, was fairly precise in what it was going to require of the CSB as far as information sharing, and that caused some concern for CSB relative to HIPAA. So you have the Hospital Association, basically, and the emergency room doctors. You had Jennifer Wicker, and I think A.B. Seibert, and then you had Jennifer Faison with the community service boards kind of arm wrestling over this. And they've come up with compromise language, which in the substitute. So I would ask you to adopt the substitute.
So moved.
So moved and seconded that we adopt the substitute. All in favor say aye.
Aye.
And just to get to the heart of the matter, it says at the very end of the bill, on page 6, in any case in which a person is subject to an evaluation pursuant to this section is receiving services in a hospital emergency department, the treating physician or his designee and the employee or designee of the communities of the local community service board shall consult and disclose relevant information pertaining to the individual's treatment in the emergency department, which sometimes can be very important for the treatment of the individual that's being evaluated there. And they some of the couple of Jennifers and Amy may be here to speak to it, but that's it.
Anybody want to speak in favor of Senator Hanger's Senate Bill 119? Yes, ma'am.
Good. No, I'm not going to sit down.
I think
But-
if you might.
Good. Can you hear me?
Yeah,
just fine?
we can hear
Okay.
you. Go ahead.
Good. Okay.
Sorry. She's got a foot, though.
She's got a foot. Good afternoon. Jennifer Wicker with the Virginia Hospital and Healthcare Association. We asked Senator Hanger to carry this piece of legislation for us to resolve an issue that sometimes happens throughout the Commonwealth related to the sharing of information for a shared patient between an emergency physician and a CSB emergency worker who's doing the evaluation. Although we did not arm wrestle, Jennifer Faison and I with the Virginia Association of CSBs have come to a compromise, and the legislation before you is that compromise. So we ask for your support and passage.
Great.
Thank you.
Next.
Hi, my name is Joanne Sequeira. I'm an emergency medicine physician and representing VASAP, Virginia College of Emergency Physicians. So we support the language. The only thing that we do feel pretty strongly about is that the word records be kept. The one, and I know there was the CSBs did not want the word record information and disclosing information in records. Part of my job is to do a medical screening exam, right, per EMTALA, and I need to know all the information I need to know in order to do such a thing, as well as do a medical assessment and a medical clearance. And the issue is that, when cardiology comes in, OBGYN comes in, they do an interview, they do an evaluation, and that record is documented in the EHR for us to look at any point in time. With the issues right now with our patients sitting for 72 hours, days, just telling us information from person to person, sign out to sign out, is not good enough. We need to see the record. And there's a lot of, unfortunately, things that are missed via when you're doing things by telephone. And so sometimes patients are trying to leave, and we don't know what's the status right now. We need a little bit more information. The other thing is, I know one of the issues was certain records, right, substance abuse records and such. If a patient has a history of some substance abuse issues, I need to know that because that is part of my medical screening. I need to know if they're on cocaine or amphetamines because I need to know if I need to get an EKG on them. I need to ask them more specific questions about chest pain.
And so these are all records that I do need, not just information. So that would be my ask.
Just a question.
Sure, Senator Donovan.
Are there not BAAs, are there not understandings between CSBs and ERs so that this is a HIPAA-secured communication of records like there are with everybody else?
And that's what we got confused about because it is, I mean, it's under HIPAA, right? I mean,
Yeah.
we should be able to.
Medical communication that's HIPAA protected.
But we keep on getting, I mean, at least the way I understand, and unfortunately Amy's not here, is that it's some things are protected under HIPAA. And, but I was like,
ER.
but to the ER physicians, and I don't get that because we are the ones treating them too.
Okay.
So,
thank you.
I think Jennifer Faison has the viewpoint of why she doesn't want to include the record.
Well, actually, Jennifer Faison with the Virginia Association of Community Services Boards, and, we, again, had worked with VHHA on this compromise language. We think that it, as VHHA as the entity that requested it, we thought it moved the ball and made sense in this environment. And so some of the concerns that are being raised with the exchange of information are, this process is working very well. In general, in the Commonwealth, there are occasions where a CSB legal counsel might advise that the entire pre-screening report is not appropriate for release, but that information, of course, that is relevant to that individual's treatment does need to be shared and is being shared. So we would support the language worked out by VHHA and VACSB in this bill, the substitute that you have before you.
All right. Any questions? Anybody else to speak on Senate Bill 119?
Move to report, recommend reporting.
Second.
Moved and seconded that we recommend reporting Senate Bill 119 as amendment in nature of a substitute.
Thank you.
Call the roll.
Senator Saslaw,
Aye.
Senator Barker,
Aye.
Senator Donovan,
Aye.
Senator Suderline,
Yes.
Senator Lewis.
Yes.
Ayes 5, no 0.
All right.
Thank you, Mr. Chairman, members of the committee.
Yes, sir. Thank you, Senator Hanger. The long-suffering Senator Peterson.
That's a ripoff right there. All right, I was here before he was.
I may have to copyright that.
Adam Evans took my seat, and then I get bumped. This is great.
All right, this hopefully should be quick. This is a,
Remember that, Peterson.
yeah, you can remember it. All right, my future law partner. Okay. That would be fun. Okay. This is Senate Bill 46. This actually should look familiar. It's the exact same bill I had last year, which came out of this committee unanimously, came out of the Senate 36-3, and then died in the House on a tie vote in subcommittee. Basically, it has to do with the quarantine statute, which, to be honest, was probably the most boring statute and unlooked at for generations until in 2020 it suddenly became the focus of my practice for a few months. But basically, the quarantine statute is dictated by 32.1, and it gives the Department of Health the ability to quarantine somebody if they come back from Africa or some other nation and they have an infectious disease, and they can be quarantined. And it's not within this bill, but under 32.1, there's a whole list of criteria about how you quarantine somebody, and it has to be the least restrictive means and the criteria you go through. Well, what happens when you quarantine a community? And that was the issue that arose in 2020. I represented clients that had their businesses closed for reasons they thought were not merited, and I brought a lawsuit, and I was eventually kicked out of court that they, quote, did not have standing because they were not an itemized party in the quarantine statute. So the meat of this bill is there is it's sort of an add-on to 32.1-48.10, which is who has the ability to appeal a quarantine order to the circuit court. But then also we add at the end lines 82 through 86 in the emergency order 44-146.17. It says basically where a governor has a quarantine order for infectious disease which impacts a community, closing schools or businesses or restricting people to their homes, that they have the same right of appeal to the circuit court as someone who, let's say, was subject to a quarantine order
as an individual. So basically, it's a standing bill.
Yep.
And it's the same bill I had last year, so there's really nothing different,
Okay.
word for word.
Any questions from the subcommittee on Senate Bill 46, the same bill we heard last year?
Right.
I have a motion when you're ready.
Well, let me just see. Anybody here to speak on Senate Bill 46, either way, for or against? We're ready for that motion, Senator Suderline.
I move that the subcommittee recommend report of Senate Bill 46.
Second.
Moved and seconded that we recommend reporting Senate Bill 46. All in favor, clerk call the roll.
Senator Saslaw,
Aye.
Senator Barker,
Aye.
Senator Donovan, Senator Suderline,
Yes.
Senator Lewis.
Yeah.
Ayes 5, no 0.
Thank you, Senator Peterson.
All right, guys, that was worth the wait.
Yeah. Senator Mason, I see you've come in the room. No.
It's all right, Dan. It's all right.
Fist bump. You're leaving me hanging.
All right, Senator Stanley. Get up here. You know it's cocktail hour, you're getting a little shaky?
No. But I got the moonshine you asked for in the car.
The gallon.
What you got?
I don't even know anymore. This one's in the crapper. Actually, I have an amendment in the nature of a substitute.
Let's move that. Somebody?
Move. Get it?
Second.
Moved and seconded. All in favor? Aye. Substitutes in front of us.
No bathroom.
Get it? Move. Okay. Mr. Chairman, members of the subcommittee, I can find my little notes here. Basically, what we have is we have the Virginia International Raceway, which is located in Danville. What they're seeking is an exception to the Virginia Department of Health's camping code because we've got, in auto racing, which of course I own an auto racing team, but this has nothing to do with that. You go to the track, and you stay there. And you bring a motor coach or a camper, and a lot of times you're bringing trailers and haulers, and they stay there. So VIR rents the racetrack 360 times a year, 280 calendar days. We have events there. Those racers, like I said, use pickup trucks, haulers, and also bring their coaches. Those coaches are not pump outs. They stay there, and then you pump it out somewhere where it's licensed to do so. VIR has multiple shower and restroom facilities all over the property, but these facilities do not perfectly align with VDH's camping code for daily permanent use under the administrative code. So this amendment allows VIR to have basically an exemption to that, which would facilitate more tourism and business, which we so desperately need in Southside Virginia. Virginia International Raceway has got 2 hotels, a bunch of restaurants there, resident villas, shooting sports, off-road trails, meeting and hospitality space. Camping is basically ancillary to their main event space use, but it's an important part of the motorsports culture. If you've ever done that, you'll see that even in NASCAR, a lot of the race teams bring their own motor coaches, and then the racers and others stay in them. So when we look at VIR's reach, they attract participants all over the world. They come for 24-hour sports events. It's a road course, of course. They have 400,000 visitors that come to VIR into Danville, which is still struggling financially and fiscally when it comes to our economic vitality. This generates $238 million annually in economic impact to the Commonwealth, which brings over $197, almost $200 million just to the city of Danville, Pennsylvania, and surrounding Halifax. So what this does basically is very specifically allows them for that exemption by describing at what point this exemption would be made. It doesn't make the exemption for any other campground, but just allows them to have this exemption so that they can have the racers and the participants camp on their property as they do everywhere else. That is the bill that I've waited so long to tell you about.
Any questions for Senator Stanley?
You sure you don't want to come back next week?
Pass it by.
Pass it by.
I'd like to get a work group going. Maybe we can put something
Is there anybody
together.
here to speak in favor of Senate Bill 86? Yes, ma'am. Please come up. Hi there.
I'm Crystal Walker. I work at Virginia International Raceway, and we support the bill. It will definitely help us increase the tourism and the dollars brought into Southside Virginia.
Okay. Anybody else? Any questions for this witness? Anybody else to speak on Senate Bill 86?
Move to report. Recommend reporting as substituted.
You sure Scott Johnson doesn't want to? He always. I'll give you a pen. There's a hospital nearby.
There's a motion.
He's saving up for the night.
There's a motion. There's a motion.
All right, second.
And it's been seconded that we recommend reporting Senate Bill 86 as an amendment in the nature of a substitute. Clerk will call the roll.
Senator Saslaw,
Aye.
Senator Barker,
Aye.
Senator Dunavant,
Aye.
Senator Suderline,
Yes.
Senator Lewis.
Aye.
Ayes 5, no 0.
All right. Senator Stanley, you're done.
Hey.
Senator Mason.
You guys run a really great committee. It's so compelling. I hate to leave. I really do. We're entertaining, if nothing. I thought I was.
Somehow I question the momentum at this point, Mr. Chairman. And I believe, and we do have an amendment, Mr. Chairman.
Are we doing anything with Senator Locke's
Oh, yeah,
bill?
I beg your pardon. So Senator Locke's bill number is what, sir?
617.
617. She would like it rolled into my 192.
All right, so is there a motion? Motion and seconded that we roll Senator Locke's 617 into Senator Mason's 192. All in favor?
Aye.
Opposed? Unanimous.
And so now we have an amendment, Mr. Chairman. I think it's amendment. Do we do amendment or sub? Because it doubles the length of my bill.
It's an amendment.
Okay, great.
So, Mr. Chairman, want me to roll?
Yeah, go ahead.
So this bill just gives the opportunity for area local health department to be run by a doctor, as it is today solely, or someone with a master's degree in public health or a doctorate in public health. This came to me when I had no idea Senator Locke did this 2 years ago, which passed out of the Senate 40-0, and then seemed to find some headwinds. But I was at our vaccine clinic and talking to a young lady who was really showing me the nuts and bolts. And I said, what do you do? And she said, hey, you should be involved with the health department. She said, I'd love to, but I can't do the job. I have a master's in public health, but I am not qualified because of the way we have to do the health departments. So that's where I came from. I didn't even know the background. The Medical Society has come to work with me. They gave me this amendment, and they love it until I stripped the last two sentences off of it, which they limited it just for a 2-year period. But the upshot is, Mr. Chairman, that since this is the way we've always done it in Virginia, the Department of Health brought me a variety of code sections that require a doctor to do because, well, we've always had a doctor doing. So that's why this amendment attempts to say, if you're not a doctor, you need to have one on staff or have an agreement with a doctor who can do the clinical side. There had been a bunch of vacancies. Mr. Chairman, you have a unique situation, which I thought would be really great for us. And depending on how this bill goes, your gentleman has worked in public health for 17 years, 13 years of public health leadership experience, but he doesn't have either of these qualifications.
You got the email.
So
Okay.
we would have to, we'd have to decide, do you want the commissioner to say or experience in order to loop your man in?
Yeah.
There have been significant vacancies in health departments. There are not now. There are 5 out of 28. They've combined from 35. 7 are now joint health departments. There are vacancies. There are 2 floating directors, which means I guess they are going to ride around. They're circuit riding public health directors, but they are doctors. So I just feel like we should open this up and give more people an opportunity to do the job that they're trained for.
And to your point, my fellow from the Accomack Northampton Health Department has successfully led that department through this entire pandemic with one of the highest vaccination rates at various times in the Commonwealth. I think Northampton is up to 84%, and Accomack is 79%, 2 rural localities. And the challenges for getting rural folks sometimes to sign up for vaccines, but as I like to tell people, my people are conservative, they're not crazy. So But he was able to, I mean, he's done a yeoman's job there, and as you said, unfortunately, we're not even qualifying under this broadening, so maybe there's something we can do about that. But any questions for Senator Mason? Senator Barker?
Sir.
Thank you, Mr. Chair. Any reason you don't want me to be able to provide this service here, even though I have a undergraduate and master's degree from a School of Public Health?
Yeah, that's right.
Not at all. Mr. Chairman, Senator Barker, I'm opening to expanding. I even thought if you had an MBA in public health, or, I mean, these. Now, one of the medical societies, and Dr. Romero's, don't let her wow you, she's pretty darn impressive.
Yeah, I've known her for a long time.
She's solid as a brick. She talked about if there is an outbreak.
Yeah.
If there's an outbreak, they want a doctor on the scene. I would respond to that saying, if there's an outbreak, we'd want someone with public health and community training who's set up a structure, who's been evaluating, could analyze the data, the region, the area, and in reliance and working with trained medical professionals, get the outbreak addressed and dealt with. So, no, if you've got a master's in public health, maybe that sounds like some sort of distinction there, but
there is. Well, it actually is because of the school that the university that I got my degrees from.
And which one was that?
Harvard.
I think I've heard of it, Mr. Chairman.
Small little school up in New England somewhere. So, but it's a little cold up there. But there they provide a doctor of public health or a master of public health only to someone who is a physician. And those of us who were in program I was in health policy and management and other types of things get a master of science in public health, but not a master of public health. So.
Right.
So what's your degree? What is your degree?
My degree is a Master of Science in Public Health.
Wow. So, Mr. Chairman, as we loop your gentleman on the Eastern Shore in, we ought to expand it to take in Harvard geniuses like Senator Barker. But I think that's a great distinction. That was one of my first questions when I asked, why just those two?
Right.
And I think I just didn't want to blow the doors off in anticipation for some issues. But I think it's conversations like that we ought to be having to expand the opportunity.
Right.
Let's see if there's any comment. Any public comment? Yes. Come up.
Becky Bowers Lanier with the Virginia Public Health Association. And I was just thinking about my husband, who has a doctorate in public health, was a hospital administrator for years and years, and he would do a heck of a job running the health department. And I have a master's in public health. I would do a terrible job.
Good disclaimer.
Yeah. But the whole premise of this proposition is to open the doors to people who are experts in public health. And I would say, given the person that you're talking about in the Eastern Shore, people who have vast experience in public health. It is not a requirement to be a physician, but it is a requirement to have a physician available. So, I'm totally in support of this, and our association is very much in support of it.
Great. Okay, thanks. Next.
I won't volunteer my husband, though.
Come on up.
Good, thank you.
Yes, ma'am.
Thank you so much. Nice to meet you. Good afternoon.
Good afternoon.
Friends, Senator, Mr. Chair. I'm Dr. Cynthia Romero, former president of the Medical Society of Virginia, former state health commissioner, and currently the director of the M. Foscue Brock Institute for Community and Global Health at Eastern Virginia Medical School. I respectfully speak in opposition to the bill as well as to the amendment. And apologize for my notes. I just want to be efficient in my time. Physician credibility, analytical skills, and clinical judgment are vital to leading local health districts. In 2018, Virginia Department of Health started testing strategies to address the vacancies in the local health department director positions, including combining health districts. And in spring of 2021, with the support of CDC funding, VDH has been able to hire 2 floating health directors who have the ability to assist in any component society or any component districts in need throughout the Commonwealth and have the opportunity to fill those permanent positions, in essence creating a mini pipeline for filling those positions. VDH is also seeking additional funding to support preventive medicine and other primary care residency programs to expose and train those trainees in VDH, hence exposing them and allowing them to learn how to work in local health department settings. Also, as a consequence of this pandemic, there is an increased interest in public health among medical students, further extending a pipeline for the health director roles. Public health is most effective when there is an engagement of interdisciplinary teams at all levels of planning and implementation. VDH has also created positions in several departments throughout Virginia, such as the Chief Operating Officer roles that are prime positions for non-physician public health professionals to fill, working with physician health district directors and providing management over many public health functions. Lastly, the job of local health district directors includes enforcing all health laws of the Commonwealth and regulations of the State Board of Health, which require clinical judgment and expertise. A large role of the health department is surveillance and investigation of diseases, often requiring the commissioner to investigate with the local health directors. Individuals suspected of having infections such as sexually transmitted infections, tuberculosis, will need examinations, testing, and treatment plans, as well as plans for getting treatment when they are reticent or deferring compliance with those plans. In addition, cases like rabies will need the knowledge of understanding when it's appropriate to confine and often euthanize animals. So in summary, strong public health strategies benefit from interdisciplinary cooperation and teams, yet physician credibility, analytical skills, and clinical expertise and judgment are vital to leading local health district departments effectively and efficiently. So thank you.
Any questions? But you've seen the amendment, right, about that? Okay.
Yes.
Okay. All right, let's see. Anybody else to speak on the bill? Let's see if there's something we can do to this to broaden it a little bit.
Yeah, I'm open to language to get Senator Barker a second career.
I was going to say,
Get your guy on
when
the...
Barker here decides to retire, let's see.
Mr. Chairman, the comment I'd make there, obviously to a very impressive professional, Dr. Romero, is that your guy on the Eastern Shore is the chief operating officer, but he still can't be the boss. He can't run shows. That's a neat title that doesn't get him to the top of the heap.
Yep.
And I do completely agree with the modern approach of multidisciplinary teams. I just, maybe where we differ is I wouldn't mind the leader of a multidisciplinary team that would most certainly include licensed physicians to be someone with Senator Barker's training, to be someone with a doctorate in public health, master's in public health, or 17 years experience. So I think that's the only place that we break on the...
Okay. Let's try this.
Okay.
Let's see, after Master of Public Health degree, can we add Master of Science in Public Health? You're covered.
All right. So, Mr. Chairman, or could we give, the commissioner approves these positions?
Yeah.
So could we somehow get some phraseology in here that gave the commissioner the ability to say, wow, you went to Harvard and got this degree, but they won't call it that. Or you've got 17 years experience running.
Well, I'm getting to that part.
Okay, I beg your pardon, sir.
Go ahead. Go ahead.
Just considering what you said, and instead of us in code defining what the degrees have to be,
Right.
shouldn't we have the commissioner decide on the most qualified person for each health district? And then it may be all physicians, and it may be that there's some districts that he decide. Do we have to define every? I mean, we don't even know all the degrees, to be frank.
I think after this amendment, we'll pretty much cover the waterfront, but.
Yeah, but for
you're right.
now, yeah. And so, but it's, yeah. And so, sometimes we're too prescriptive, and we don't really know what we're doing. And so, I feel like if we were to give it to the commissioner, it might save us from coming back here and adding more things to this later or solving another problem. And having the guidelines in there about clinical duties managed by a clinical leader, whatever you want to say. That I like the amendment, but I'm just wondering if we need to define the degrees.
Your bill.
I'm open if we could come up with some phraseology that would allow the commissioner to deem someone qualified to run the specific health department. I just don't know how to wordsmith it, and I can work on that with you. And I should say, that, coming into this thing, I thought the medical society was just going to be a problem. Maybe testifying against the bill is a problem, but they were nothing but helpful the whole time.
Because Johnson's
walking
asleep.
through what we had, but
Where's Stanley?
except for Scott Johnson. I should at this point know. Well, yeah, you just.
And Mr.
But
Chair.
they were not a problem.
Just to follow up, there obviously there's a huge value in having a physician, at least one involved in all of this. But I love the idea of residencies and having people actually invested, training young people that are involved in our public health process, that are innovating it and kind of enlivening it, instead of just who can we get that fills these credentials to do this job that's tough. And so I love the idea of us expanding the scope, but I think we need to have flexibility for making sure. I want our health departments managed. I mean, they really need to have astute managers, and that may be a hospital administrator with a clinical consultant, or it might be the other way around.
Yes, ma'am. All right, so do you want to try and do this between now and committee?
We can do that. I mean, I can read what I have in mind.
Okay, sure, shoot.
The code section would just read, each county and city shall establish and maintain a local department of health that shall be headed by a local health director. Each such local health director shall be appointed by the Commissioner of Health.
Needs to have something about medical. You need to have the medical director for clinical decisions, and it needs to be a physician or.
Okay, then we can work on that because it's
what they call it,
I don't know.
Collaborative arrangement.
Multidisciplinary approach.
All right, should we try that before committee, or you want to come back next week?
No, we can do it before committee.
Before committee? Okay, all right, let's do that. That'll save everybody a lot of time and trouble. All right.
Thank you, Mr. Chairman.
Good deal, thank you. All right, I think Senator Barker, you're next, are you not?
I presume so. I don't see
So
anybody.
before you run me out, Mr. Chairman, we're sending this up with no recommendation and getting it squared away in between, and we'll show up at full committee to do it?
Well, it's kind of hard to recommend.
Or,
No, I don't think anybody wants to come back, and I don't know what the docket looks like, and we've already carried 2 over for next week.
I think we can, with pending substitute for consideration of the full committee.
Yeah, we're there on the full committee. We can represent to the chair of our consensus.
We got you.
okay, good. Thank you, Mr. Chairman, members of the committee. I appreciate it.
All righty. And you have one, Senator Barker, SB 340 that you want to go by for the day.
Yeah,
And so
Senate Bill
without
340 will have go by for the day.
objection, by for the day.
Be addressing that.
Senate Bill
next week.
340.
Yeah.
And so now we're on Senate Bill 436.
Bill 436, which is a pretty straightforward bill. There is a short amendment to that. Oh, you haven't seen it? Oh. The amendment on line 26 it says, right now it says, the board shall leverage the expertise of the Virginia Telehealth Network, and this just says that the board shall contract with the with the Virginia Telehealth Network, et cetera.
Okay.
What this bill does is there's a statewide telehealth plan that is developed, and this just is designed to make sure that there is input into the process of what needs to be incorporated in the state telehealth plan, and to involve a variety of people in that process, including the Virginia Telehealth Network, which is actually one of the leading ones around the country in terms of what they do to promote telehealth services and to define things that need to be done. So with that, I would be happy to answer any questions that anyone would have on things. I think this will continue to move us forward. We have become sort of a leader in telehealth, and I want to make sure that we continue heading in that direction.
Okay, are there any questions for Senator Barker on Senate Bill 436? All right, is there anyone to speak in favor of Senate Bill 436? Are y'all, I see movement, okay.
Obviously, Wazowski with the Virginia Telehealth Network, we thank Senator Barker for doing the bill and obviously support it.
Okay. Great.
Julie Dime, the Hospital Association, ditto.
Okay. Good for you, Julie.
Veterans for Prosperity ditto.
Okay, even better. All right, anybody possibly speaking against 436 at 5:30 in the afternoon?
It isn't so.
All right, very good. We've got 436 as amended in front of us.
Approve, recommend report with amendment.
Second.
Moved and seconded that Senate Bill 436 as amended be recommended to be reported. Clerk, will you call the roll?
Senator Saslaw,
Aye.
Senator Barker,
Aye.
Senator Dunavant, Senator Suderline,
Yes.
Senator Lewis.
Aye.
Ayes 5, noes 0.
Wonderful. I believe that completes our work. Thank you all. Committee's adjourned.